Hello and good afternoon. My name is Hugo Rodriguez. I am a member of the Levy Senior Center Foundation Board of Directors, and we're very happy to welcome you to today's Levy Longevity Program on Brain Health Part 2, presented by Dr. Kenneth Grumet, who is backed by popular demand. This longevity series is presented in conjunction with AMITA Health and the City of Evanston. In these sessions, common issues of concern for adults 55 plus will be discussed so we can learn ways to live well and age gracefully. As always, we appreciate your support of the foundation as we continue to work to connect our community of older adults. I'd like to now turn things over to our wonderful moderator and partner in organizing these programs from AMITA, Samantha Cochran. Sam?
Thank you, Hugo. My name is Sam Cochran, and I am an athletic trainer by trade and the sports medicine liaison in the Chicago metro region with AMITA Health. I'm going to start off by going over some housekeeping items. First, all attendees are muted for the duration of the presentation. Questions may be submitted using the Q&A feature in the bottom center of your screen. Please do not use the raise hand or chat feature or attempt to unmute. We will not be able to hear or see you. Next, at registration, you were able to pre-submit questions. Similar questions were grouped together and addressed in the presentation. Additional questions will be answered at the end of the presentation during the Q&A portion. Additionally, it is not permitted for this presentation to be recorded by attendees. However, it is being recorded and will be available on the Levy Foundation YouTube channel and website. Lastly, this presentation is intended for information purposes only and is not intended to replace individualized care provided by your respective doctors and/or practitioners. AMITA Health and the Levy Foundation are not liable for the misuse of any information presented today. Now, I would like to introduce you to our speaker. Today, we have Dr. Kenneth Grumet back with us. Dr. Grumet is an internal medicine physician with AMITA Health that specializes in geriatric primary care with an emphasis on brain health. He has a passion for helping people overcome their health challenges through preventative care, utilizing a team approach to medicine. Today, he will be speaking on the health of the human brain and go into more in depth of disease of the brain as we age. Dr. Grumet, I now turn it over to you.
Good afternoon. Thank you for listening in today. I'm going to give you the second part of the series, Aging in the Human Brain. This is kind of a little like medical school, a first year of medical school. You learn, how things occur normally in the body, whatever body system it is, the brain, the heart, the lungs, things like that. And in your second year of med school, you start learning about pathology, the diseases of all of these systems. So today we're going to go from part one, which was the normal aging brain. We're going to move on now into some of the problems that occur in some of the diseases. So next slide. So what I have is an outline here, and I'll keep referring back to this outline so you'll know where we're at. I'm going to start with the bibliography, and we're going to go from there to a brief review of lecture 1, normal aging in the human brain. Then we'll discuss mild cognitive impairment, followed by dementia in general. Then we'll go into the non-Alzheimer's dementias, and finally into Alzheimer's disease. I'll describe the disease itself and some of the things that we're doing to help prevent it and to treat it. And then finally, actually prevention itself. A lot of that will be similar to what we discussed in the first lecture. So if you go to the next slide, please, Sam. So why am I starting with the bibliography? Well, this is just a follow-up from the last lecture. We had gone so long in the last lecture that I just did not get around to putting the bibliography in. So I'm doing it at the beginning so we don't get lost at the end and forget to do it. Next slide of references here. And I'll leave that. And when we go to the next slide in a second, I'm going to give you some, a few of you have called me and asked me, gee, I was really interested in the topic. What else could I do to read? So next slide. So especially from the first lecture, Aging the Human Brain, Part 1, I just want to make you aware of a series of lectures called The Aging Brain, and it comes from the Great Courses. And you could find the Great Courses online. I think it's www.thegreatcourses.com. And this is an excellent comprehensive lecture series on cognition in the normal aging brain, with lectures also on dementia, strokes, some of the things we'll talk about today, as well as additional lectures on aging in general and some of what the future may hold for aging in terms of some gene manipulation. It's presented by Dr. Thad Polk. I used a lot of this myself for organizing, especially the previous lecture, and I highly, highly recommend it if you're looking for a deeper dive into the topic. As far as part 2 today, you should all know about the Alzheimer's Association. Very simple. It's www.alz.org. And it's an excellent source of information on dementia. Whether you're just interested in the topic or you have somebody in your family who has dementia, or you're a caregiver, and they have everything from just general information about all of the dementias, as well as trials that may be going on, tips on caregiving, things to look for. It's an invaluable resource for both professionals and just for anybody who has an interest in it, and especially if they're caring for someone. I have a couple of others I didn't put up here, a couple of other books that you might consider. One is called The 36-Hour Day by Mace and Rabins. This is a classic. It goes back at least 30 years, I think. And I ask all of the families of Alzheimer's patients to read that book at some point. It's very empathetic, and people will say, yeah, gee, that's me. And it really gives lots of advice on how to understand and take care of people who have Alzheimer's disease. Another very fun book that I read many years ago, it's called Where Did I Leave My Glasses? The What, Where, and Why of Normal Memory Loss. It's by Martha Lear, Lear as in King Lear. I highly recommend that book, just if you're looking for something light to read. That's very, very informative. And there's a recent book called Exercise. It's a little bit technical. It's not meant for physicians, by Daniel Lieberman. And he specifically talks about exercise and the evolution of exercise regarding especially how it benefits us. So let's get started. Next slide. So now I'm going to do a brief review of lecture number 1. It will be brief. And if you're just coming in and did not listen to lecture number 1, I think I'll have the basics of what you need. Next slide. So there are 3 things that decline normally as you age. One is decreased episodic memory. The second is decreased processing speed. And the third thing is decreased executive functioning. Next slide. So when we talk about decreased episodic memory, just to remind you, episodic memory is almost an autobiographical memory. So you remember things based upon where you were and you know when it was that you learned about a certain event. So for example, I think we're all over the age of 20 here, so or 25. And if we talk about what you know about the 9/11 attacks, you would probably be remembering most of that from episodic memory, because you'll think about it in context of where you are when you learned about it and what you were watching. Episodic memory, remember, is both long-term and short-term memory. So in normal cognitive aging, we kind of see a somewhat small decline in both long-term and short-term memory. As far as the anatomy, and it's a little bit important here because we'll be going back to the hippocampus. As far as the decline in episodic memory is concerned, it correlates with shrinkage of the hippocampus. The second thing that declines with normal aging is processing speed. And with this, you can perform the same cognitive tasks that you did before, but you're a little slower at it. So for example, if you lifelong you do a particular crossword puzzle, if it's you know from from the New York Times, or if it's from your favorite magazine and you do it once a week, you might notice if you're 75 years old that you still are just as good at doing them, but it just takes you longer to do it. You may have been able to knock them off in 45 minutes, 20 years ago. Now it takes an hour, 10 minutes, things like that. So you're just as good, but you're just slower at it. This is considered a white matter function. We're not going to really go into that too much, and it's not terribly important. And the third thing that declines with aging is executive function, especially working memory. I won't go over the examples that I gave the last time, but it does account for a noticeable but mild decline in multitasking. That is something that you might notice at age 70, 80 years old, that it's more difficult to do 5 different things at the same time, or at least keep them within your memory. This correlates with shrinkage in the prefrontal cortex. Next slide. These declines are progressive and they're regular, starting at, and get this, age 20 to 30. The decline, when I say progressive, if you kind of look on a graph, you'll see it starts to decline as early as 20 or 30. More recent studies kind of push that to the right a little and say maybe more like 35 or 40, but certainly it's it doesn't start at age 60. So it's progressive. We notice it more as we get older, not just because it's a little bit lower, but some people say because we're just a little bit more concerned about it, and we think, oh gee, our memories are declining, and so we're a little bit more concerned about it. Remember, the degree of decline in these brain areas or domains do not approach the level that's seen with dementia. So this is normal aging. It is not as severe as we see with dementia. And most importantly, they do not interfere with the ability to function independently in everyday life. We'll talk about this a little further when we get to dementia. Next slide. One particular type of memory called semantic memory is maintained. And if you recall, when we talked about semantic memory, of course, semantic, we think of words and language and things like that. It's also associations. So for example, we know that giraffes have long necks, zebras have stripes, birds have wings, turtles have shells. So we know that this is considered semantic memory. And why it's not episodic memory, because for the most part, you don't remember when and how you learned that. So it's not episodic memory, it's called semantic memory. Performance, however, remember, may be slower because things work slower. So for example, this may be one of the results of what we call tip of the tongue phenomena. We all have it. So if you forget a word and it comes back to you a little later, that's just plain ordinary tip of the tongue phenomena. It occurs in everybody. It occurs in 20-year-olds and 30-year-olds. It does get a little worse because things go slower and retrieval takes a little more time. I'll give you a sort of hint number one. People always ask me, they say, gee, is this early dementia? Well, my answer usually, we all get this. And I usually say to the patient, if an hour later, it comes back to you, the first thing you do when that happens, it's this. That's called the dope slap, all right? You say, oh, that was the word. So obviously, if an hour later you've remembered what you forgot, that's a good sign, okay? Usually with dementia, you will never remember that you had forgotten something. Next slide. So let's talk about mild cognitive impairment. Next slide. So this decline in cognitive brain function is pathologic. So this is not normal aging. There is decline in brain function. And there is, however, no change in the ability to manage independent living due to the decline in the cognitive brain function. Next slide. So I don't have a cursor here, but if you look at the top left-hand side, it says normal cognitive aging. And notice the diagonal arrow that goes downward to no progression. So most of us go through normal cognitive aging with no progression to anything else. However, there are some people, if you follow the other arrow from normal cognitive, some people do develop mild cognitive impairment, and they don't develop it because they had normal cognitive aging. They just develop a mild cognitive impairment, which I am going to describe further. Now, if you take a look at where those two arrows go from MCI, mild cognitive impairment, if you look to the right, a lot of 50% will, and that's a number, 50% never progress from there. And actually, I didn't show it, but there are actually some people, up to 10, 15% that actually go back to normal cognitive aging. But 50% do go on from there to dementia. So if you do have a diagnosis of MCI, it's probably 50-50 as to whether or not you will progress on to dementia. Next slide. So these are those numbers. So if you've been, or someone has been diagnosed with mild cognitive impairment, there's about a 10 to 20% chance that that person will convert to a dementia, usually Alzheimer's, every 2 years. And 50% of people with MCI, mild cognitive impairment, will never convert to dementia at all. So what are some of the other reasons that they have MCI? Well, one is general arteriosclerosis, hardening of the arteries of the brain. Another is nutritional deficiencies, especially some of the vitamins. I'm not going to go into it extensively, but vitamin B12, folic acid, thiamines, some of these deficiencies will lead to a decline and pretty much a pathologic decline in cognitive abilities. People who have depression or other psychiatric illnesses may present this way as far as their cognitive. And another one, of course, is medications. There are lots of medications that will decrease your cognitive functions. There are other cardiovascular conditions that I have seen often in the past. People come in with a cognitive decline that ranks as mild cognitive impairment. And for example, I've seen very, very, very tight aortic valves, and they're just not getting enough blood going to their brain. Of course, in these cases, these are correctable. Another one is an arrhythmia where perhaps the heart rhythm or the rate drops to something like 30, 35. They're not thinking straight, or it can actually be going up very high to 200. These people are just not getting enough blood flow to the brain. That also, of course, is correctable. And then sometimes we're just not sure. And, sometimes there's somewhere between that borderline between normal aging and MCI, and check them again in a year or two, and they've reverted to normal. Next slide, please. So, can we predict who of those patients with mild cognitive impairment will convert, that 50% group, to Alzheimer's dementia? Well, people who have the memory loss type of MCI are a little bit more likely to progress. Most people with memory loss are not going to progress, but if they do have memory loss, there's a higher chance that they'll progress than if they presented with a different domain, such as executive function, things like that. Genetics, there's something called ApoE4. There's a few questions in here that were sent to me about ApoE4, and I'll try to answer those later. But it's a gene. I won't go into it right now into detail, but if you have that ApoE4, it's a little bit more likely that you do have the type of MCI that will progress to Alzheimer's. And then there are positive biomarkers. We're going to talk about this later extensively. There's something called the amyloid PET scan, which is not paid for yet by Medicare. And there's what we call CSF analysis. That stands for cerebral spinal fluid. And that comes from a lumbar puncture, which you may know as a spinal tap. So we can look at that fluid. We rarely do it, but we'll talk about it further. And there are certain things that we look in there to be pretty certain if someone is going to be developing or they are developing Alzheimer's disease. Next slide, please. So now we're going to talk about dementia. Next slide. So again, just like with MCI, there is a progressive pathologic decline in cognitive abilities. But in order to be dementia, it has to be combined with a decline in the abilities to maintain the previous level of functional independence. And I'm discussing loss of functional independence being caused by the cognitive decline. So if someone has had a stroke, they can't walk, the left side is not able to move, and they can't do certain things to maintain independence. That's not what we're discussing here. We're talking about people who can't do some of these things because of the cognitive declines. And I put a number 3 here. It may or may not, in the early stage, be accompanied by emotional behavioral changes. I'll describe some of those a little later, but you don't have to have depression or anxiety or agitation to be diagnosed early on. Next slide. Now, once again, I have to say that the intensity of the cognitive loss is substantially greater than it is in normal aging, as we've discussed. These changes are measured by medical personnel using any of a number of evaluation tests. We like to call tests in medicine, we like to call them tools. So these tools or tests can be performed by doctors, nurses, physician assistants, nurse practitioners, psychologists, or other medical personnel. They usually take 10, 15, 20 minutes, and this can be practically diagnostic by itself, or it can usually lead to further testing. These tools or tests that we use, they test many brain domains, such as memory, of course, attention span, visual spatial function, which I'll describe later, executive function, and speech and language, and other different brain domains. Next slide. So I've listed here on the left and the right the independence functions. So on the left, we have the most basic functions, the activities of daily living. So do people have troubles with bathing, with toileting, using the toilet, transferring, and we're talking about able to transfer from bed to sitting, sitting to standing, or if people are in wheelchairs, going from bed to wheelchair, wheelchair to toilet, things like that. Feeding. So here I'm talking about, can you feed yourself? If you're given a plate of food, a knife, a fork, a spoon, can you actually feed yourself? Can you dress yourself? And then continence, it's kind of a funny one. It's in this list, but incontinence may or may not be related to other cognitive issues. Usually is not. It's a very common thing. So as you look at this column on the left, the ADLs, the activities of daily living, these, as you see, are super basic. Most patients who are coming in to be evaluated for the possibility of an early and even moderate dementia very often are still capable of doing those ADLs. So what about the column on the right, the I ADLs? I stands for instrumental, but you can actually put independence in there. That works too. So instrumental activities of daily living, these are things such as using the telephone, shopping, meal preparation, not eating, but actually preparing a meal, light housekeeping, using transportation. Obviously, if you drive, you drive. If you don't drive, being able to arrange and use other transportation, such as buses and things like that. Managing medications becomes very, very important. And then I left for last, managing household finances. That one, to me, is the key as to whether a cognitive decline has reached the level of dementia because they're not functioning independently. And for a lot of you, and I can't tell you how many questions I've had as what exactly is normal aging and what is not. You, even on your own, can see if you can still deal with your household finances the way you always have, assuming that you're the one who's dealing with it, of course. If you can still do it as the way you always have, then usually this is not a dementia. So, for example, you get your bills. If you get them in the mail, you make 3 piles. One pile is stuff that has to be paid today because otherwise, something will get cut off. The middle pile's got to get paid by the middle of the month, and the ones on the right, like from your doctor's exam, just push them aside. I'll get to them some other time. You still are able to manage this. Whether you have enough money in your checking account is another story, but at least you understand how these things are supposed to work. And you're still doing, I'll find people who have dementia, they've lived on their own, and people will go into their house and we'll see bills just thrown all over the place. They haven't been paid in 6 months or so. Next slide. So what are the types of dementia? So the first one, of course, the most common one is Alzheimer's dementia that makes up about 65%. The second one is vascular dementia. We'll discuss this soon. That's about 20%. Lewy body dementia, 15%. Frontotemporal lobe dementia, about 10%. And then there's a handful of other more rare things. Now, if you're doing the math in your head, you notice that it's greater than 100%. And that's because there are mixed dementias. Most of those are mixed with vascular dementia. And there was actually a study in Florida where they actually did autopsies, and they found they actually were able to come up with 139% because of a lot of mixed dementias. Next slide, just a pie chart here, and if you see the green is Alzheimer's dementia, and on down the line of just what we were talking about. Next slide. So let's start talking about the dementias, and we'll start talking about the non-Alzheimer's dementias. Next slide. The first non-Alzheimer's dementia we're going to talk about is vascular. So I'm only going to talk to you of the vascular dementias about multi-infarct dementia. There are some others which I'm not going to go into for time, and they are not the most common vascular dementias. So when you have multiple strokes, we just talk about that as multi-infarct dementia. Remember that many strokes are often silent. What I mean by silent is they're not the type of strokes that cause physical changes. If you're familiar with the big three things to look for in a stroke, you know, if you wake up in the morning and half or part of your face is asymmetrical, if you have difficulty moving an arm or a leg, or you have difficulty with your speech, you can't get the words out or they're very slurred. Well, there are lots and lots of other areas that can have strokes, and you just don't know it. You will totally go through the episode and not even know it. May not be a pleasant thought, but that's what happens. So what are the risk factors for strokes? So of course, you probably know a lot of these already: smoking, high blood pressure, diabetes, elevated cholesterol, just having a family history of this, and then atrial fibrillation, which is a specific type of abnormal heart rhythm. The progression of multi-infarct dementia is a little bit different than what we talked about in terms of a progressive decline. This decline is more of a stepwise, and of course, it has to do when you have the stroke. We still call it dementia because it follows all the other criteria of a dementia. So, but it is kind of a stepwise thing. It's not uncommon for someone to come in and bring their father in and say, gee, you know, it's like September 1st now, and ever since the middle of July, he hasn't been himself. And then we go through, a whole history and things like that. And I'll ask a question, have you seen anything similar? And they'll say, well, yeah, about a year ago, he had to quit working because he just all of a sudden wasn't himself, and we decided it's time to retire. So this is an example of how that might work in progression. Next slide. So the prognosis is good for preventing progression if the underlying risk factors are managed. And these, again, are the risk factors we talked about: smoking cessation, managing hypertension, cholesterol elevation, and diabetes. And I'm not going to say that 100% of people who have atrial fibrillation require anticoagulants, but a lot do. Your physician would determine this. Physician may recommend aspirin or other antiplatelet agents, or even a statin, of course, for high cholesterol. Even if the cholesterol is normal, there are a lot of doctors will start you on a statin if that's the case. Next slide. The second non-Alzheimer's dementia I'm going to discuss with you is called Lewy body dementia. And here the brain damage is caused by the production of something called Lewy bodies. It's caused by an accumulation of an abnormal protein. It's not necessary to remember what it is. It's called alpha-synuclein, however. Clinically, with Lewy body dementia, there's a progressive and simultaneous decline in both cognitive function and the development of a physical Parkinsonism. So by Parkinsonism, what I mean is features that are very similar to Parkinson's disease, but it isn't pure Parkinson's disease. So these are people who have a parallel development of a cognitive decline and Parkinson's features. Some of those features are especially slowness, especially in walking, general rigidity, there's stiffness of their arms and legs. They have a tendency to fall backwards. We usually think of Parkinson's disease as having a tremor at rest. We don't often see that. We sometimes do. I have, but that's not necessary to make that diagnosis. And usually these deficits we're talking about are usually equal on both the right and the left side with Parkinson's disease. It usually starts on one side or the other and then progresses. Next slide, please. Another very, very, very key thing about this is visual hallucinations are seen very early in the course. When I'm evaluating somebody with an early cognitive decline, if I find that there is a new onset of visual hallucinations, I'm thinking that this is most likely Lewy body dementia. There are often fluctuations in the presentation, so their history will be such, you know what, they do great, and all of a sudden they have problems, and then all of a sudden they have a good hour or a good day. There's also something called REM sleep disorder. REM, of course, means rapid eye movement, and it's a phase of sleep. We dream during that. So what is REM sleep disorder? It's dream reenactment. So if you kind of know something about this, during REM sleep, A, we dream, B, our eyes move back and forth with the lids closed, and 3 or C, is the rest of the body is paralyzed, can't move your arms and legs. However, with this disorder, there's vocalization and complex purposeful motor movement. So people are actually living out this dream. So they'll be talking, and it's not all that. This is not everybody who talks in their sleep, but this is related to that dream, and they may be moving their arms and legs. But if it's just the legs, we may be talking about restless leg syndrome. So just don't be too concerned. And everybody with dream reenactment is not, a REM sleep disorder is not necessarily going to get a Lewy body dementia, but we often will see this as we're taking a history. And it is found in about 80% of cases. Again, it doesn't mean that 80% of cases, people with REM sleep disorder will get Lewy body, but people with Lewy body dementia, 80% of them will have this in their history. Next slide. People with this have an excellent initial response to medicines we call the cholinesterase inhibitors, such as donepezil, very commonly known by the trade name Aricept. They respond very well and very quickly to this. The benefits, however, is only temporary. I've seen them last 6-12 months. There are no disease-modifying treatments. I am going to define disease-modifying treatment for you. So when we talk about a disease-modifying treatment, we're talking about something that attacks the thing that's actually causing the disease. So here we talk about Lewy bodies as causing the problem. So a disease-modifying treatment would prevent or decrease these Lewy bodies. We do not have that for this disease. The prognosis is generally poor, with survival about 5 to 8 years. If anybody has this, I usually recommend that they consider going into a trial for it. Inheritance of this, so people who have Lewy body dementia, we find about 10% have a family history, so it's not tremendously congenital. Next slide. I'm going to talk about frontotemporal lobe dementia. With this, there's damage to both the frontal and temporal lobes of the brain caused by either of two abnormal proteins that seem to develop in these two parts of the brain, the frontal lobes and the temporal lobes. One is abnormal tau, and the other is something called TDP43. The age of onset of frontotemporal lobe dementia is often earlier than many of the others. It's in their 50s. They may present with one of two different variants. One is called the behavioral variant, and the other is the aphasic or speech and language problem. The particular presentation, which way they may present, depends on which lobes, frontal or temporal lobe, and which side, either the dominant or non-dominant hemisphere, is affected first. Eventually, usually in this disease, both lobes and both sides, dominant and non-dominant, become affected. One thing of interest when we talk about different brain cognitive domains, memory and visuospatial, I'll talk about that soon, are usually rarely affected with this problem. So usually they're able to, have normal memory for their age, and they have no trouble recognizing what they are seeing. Next slide. So for the behavioral variant, the key to this is that they have socially inappropriate behavior, and this inappropriate behavior is often of a sexual nature. So if you know someone in their 50s or early 60s who suddenly become they're usually in their language or even touching, in a very, very abnormal way, something, and especially very, very very different for this person. This may be the beginning of the behavioral variant, frontotemporal lobe dementia. They also have poor judgment, which goes along with the inappropriate behavior. They have apathy for a lot of things. They have anosognosia, which we're going to talk about later with Alzheimer's. And that anosognosia means a lack of insight into their medical condition. They even after a discussion from a physician or somebody else, they just have no insight into the fact that there's a problem. Other features are compulsiveness and hyperorality. Hyperorality means they always have something in their mouth. They always see them like this with a pen in their mouth. In fact, they also eat a lot. A lot of times they'll actually gain weight because they're always trying to put food in their mouth. Next slide. The aphasia variant. Aphasia means lack of speech, and that means difficulty with speech. It may be an effortful or halting speech with a lack of grammar, or sometimes they present just with single word errors in the middle of an otherwise comprehensible sentence. So this latter part would be, well, they'll give you a normal sentence, but there's a key word in there which has been substituted and has no meaning. Effortful, halting speech, lack of grammar. One test might be if you show them a picture, let's say, of a picture of the ocean with a fishing boat there, and there are men that are pulling their nets in the background you see some dark clouds and some lightning, for example, and you ask the person to describe this. They may just say boat, fisherman, storm. So they're not giving you a full sentence or two describing what they see. And that would be the aphasia variant. Yeah, next one. That's right. Next one. Prognosis is poor for this disease. There's usually a rapid decline over a few years, 2 to 3. Treatments are focused on really managing the individuals with emotional behavioral needs. There is no disease modifying treatment. I usually recommend everybody with this to certainly enter a trial, because there are trials of various medications and other things to treat this condition. Next slide. So I also included other, which means other rarer conditions. I'm not going to go into these a lot, except really for 2. One is called normal pressure hydrocephalus, and this is a cognitive dementia accompanied by a very unique gait or walk. It's described as the Frankenstein gait, or the stuck in mud gait, or the magnetic gait. And if you can remember back to some of the earlier Frankenstein movies from the 30s, 40s, and 50s, you saw him with very heavy lead boots. And as he would walk, he could hardly lift his leg up. He would pretty much drag it. So that's the type of gait that we do see with normal pressure hydrocephalus. Urinary incontinence is also present, but remember, this problem is very, very, very common in the aging population. And when I have someone who comes in with urinary incontinence, pretty much the last thing I'm thinking of is normal pressure hydrocephalus, unless there's a cognitive decline and there is a specific gait. 2 good things about this is that usually on an MRI or even a simple CAT scan, we can rule this out as a problem. There are some very, very specific things we see on those type of x-rays. And the good news is it's totally curable if you get it at a reasonably early stage with a very relatively minor surgery. I don't know if any of you remember Bullet Bob Feller. He was a pitcher for the Cleveland Indians in the late 30s, 40s, and 50s. He did develop this disease, and about 10, 15 years ago, he actually he put out a commercial for he had normal pressure hydrocephalus, and it showed a picture of his walk before and perfectly normal walking after he had this surgery. The second type of other for non-Alzheimer's dementia is the dementia of Parkinson's disease. Now, not everybody with Parkinson's disease is going to get dementia, but when dementia does accompany Parkinson's disease, it's usually late in the course of the Parkinson's disease. It is treated with cholinesterase inhibitors, and one of them, ribociclib, also known as Exelon, actually has an FDA indication for this. By the way, when I mentioned that these cholinesterase inhibitors are used for Lewy body dementia, it is not FDA approved for that, but we use it anyway on an off-label basis. Next slide. There are other non-Alzheimer's dementias. Some of them are infectious. Syphilis can be one. HIV. Now, once again, HIV it very, very rarely produces dementia. But if I have a 45-year-old patient who has developed a dementia and they are HIV positive, this would be a consideration as one of the causes. And I'm not going to go into the other rare ones, although Huntington's disease is one. Next slide, please. So now we're going to talk about Alzheimer's disease. Next slide. So, of course, Alzheimer's disease accounts for about 2/3 of all cases of dementia. When we showed you the slide before, I told you it was about 65%. So I'm gonna try to differentiate Alzheimer's disease from Alzheimer's dementia here, because I'm going to be going back and forth and using the words, I hope, correctly. And sometimes I'll say disease and sometimes dementia. So Alzheimer's disease refers to the years, usually more than 10, in which the pathologic process begins. We call it Alzheimer's dementia when the features of dementia, the measurable cognitive loss and consequent inability of functioning independently, do occur. So it starts out with Alzheimer's disease and then becomes Alzheimer's dementia. Now, a parallel situation might be heart disease. So when someone suddenly develops angina or a heart attack, you will say, gee, they have heart disease. But actually, the disease started decades before, when people were developing hardening of their arteries and narrowing of the coronary arteries. So this is kind of a later, an angina or heart attack might be, not every case is due to this arteriosclerosis, but it most likely is the process started decades earlier. Next slide, please, Sam. So I am going to ask you to remember especially amyloid plaques, and I'll go in, it'll become obvious why when we talk about treatments. So Alzheimer's disease is caused by the accumulation of two things that we see on a microscope. One is called amyloid plaques and the other is neurofibrillary tangles, so plaques and tangles. Next slide. So amyloid plaques are formed by the accumulation of beta amyloid. It's a particular type of amyloid called beta amyloid. It's a protein. The deposition in the brain of this abnormal protein causes the disruption of normal neuron to neuron signaling. And the neuron is the brain cell that you've probably seen pictures of. It has the long axon and the many different spikes that come out of there. And they attach to dendrites. So they connect and signal between each other. So the amyloid plaques do disrupt this signaling. Some of the areas in the brain in which these plaques occur are the hippocampus, as you remember, responsible for memory, the prefrontal cortex, responsible for executive function, and then areas, I won't even name them, that have to do with speech and language and interpretation of visual images. Next slide. The tangles, these neurofibrillary tangles, are caused by the accumulation of something called abnormal tau. So there's normal tau, which is important, but tau can become abnormal. These tangles also cause the disruption of normal neuron to neuron signaling. It's believed that the production of normal to abnormal tau is caused by the presence of beta amyloid. So that's why we think beta amyloid is probably the key to all of the things that we're seeing. Next slide. So a little bit about the history of Alzheimer's disease. It was described first by Alois Alzheimer at the beginning of the 20th century. He published a report in a psychiatric journal because he was a psychiatrist. The case report included a single patient's clinical history and autopsy findings. He described the amyloid plaques and the neurofibrillary tangles found under the microscope. The term Alzheimer's disease, and he called it disease at that time, was coined by a colleague in 1910. And the term Alzheimer's disease was used exclusively for patients less than 65 years old until 1977, fairly recently, I think fairly recently, because of my age, and I was in medical school at that time. Patients with this same disease, older than 65, were simply said to have senile dementia. Next slide. Eventually, 1977, it was understood that the clinical findings and pathology findings, the amyloid plaques and tangles, were identical regardless of the age, and the term Alzheimer's disease was used for those people above and below age 65. So in terms of clinically how these people present and the pathology, it was identical whether they were 45, 50, 65, 80, or 90. I don't want to go into too much detail here, but this explains why patients under 65 will get Alzheimer's disease. It was subsequently discovered that there are actually 3 different mutations in genes that cause an early development of Alzheimer's disease. These are the 3 mutations. I'll just kind of leave it on the slide there. Family members with any of these 3 mutations, this is autosomal dominant, develop the dementia as early as their 30s or 40s. And by saying autosomal dominant, it means that if a person with this dementia has passed on the bad gene, so there are 2 genes, they will have only one of them that will be the abnormal one. If just one of them, it means that the next generation, half of their children, statistically will have it and half of them will not. Next slide, please. So this is the seminal patient. This was Dr. Alzheimer's patient. Her name was Auguste Dieter. And surprisingly, although she doesn't look it, she's only 50 years old here. So she was one of those patients who had one of these mutations. Next slide. Just a little epidemiology, 6.2 million Americans older than 65 have this. It's projected by 2050 that 13 million people will have Alzheimer's dementia. And here's some good news. Despite the increase in the actual numbers, and that's because we have a growing population. So despite the increase in numbers of people with Alzheimer's dementia, the rate of new cases, the incidence, has declined by about 15% in the past decade. So we're actually seeing we're seeing more patients, but a smaller percentage of people getting them that got them before. Next slide. So there are 4 cardinal features, and I have to tell you, this is my personal experience. These are the 4 things I look for when I'm making a diagnosis of Alzheimer's disease. One is memory deficits. Another is speech and language deficits. Another is visual spatial deficits. And the 4th one, as I talked about before, is anosognosia. I'll describe these now. So next slide. Now, the memory deficits, and if you remember, we talked about episodic memory does decline with age, and semantic memory does not. So episodic memory, initially, short-term memory is affected. And if we talked about normal aging, we did not distinguish between short and long-term. But initially with Alzheimer's disease, it's short-term memory that's affected. The memory deficit is considerably worse than in normal aging. So, there's a degree that's much different than the normal aging memory deficit. The memory deficit causes everyday functional problems. So it's not just that they forget things, they may forget the name of something. This causes an inability to do some important things that they have to do in everyday life. And the primary brain area that's affected is the hippocampus. These patients also have a decline in their semantic memory. And these are memories for words and word associations. And recall that we talked about normal aging, semantic memory does not decline. It in many cases improves even in your 60s and 70s. So this is a key difference in the memory of patients with Alzheimer's disease. Next slide. Speech and language deficits. It's sometimes difficult to detect early on, even difficult for a neuropsychologist to assess because there's a tremendous variation in population. So, for example, when we determine how someone's memory is, we often compare it to, we will often compare it to their score to how many years of education that they've had. But in this particular case, it's still difficult because, let's say, I'm going to just say for an example here, let's say you have 5 people who graduated from college. You may find some people who are very, very verbose, loquacious. They, they're very, very good at putting things into words. And you may find other people with that same level of education that are just not as articulate. So they may note that the patients are no longer participating in word games. This is something I would do when I'm talking to a patient, perhaps with a spouse. Is I'll ask them, have they stopped doing things like crossword puzzles, Scrabble, Jumble, word search? And sometimes they'll do it. They won't say because, gee, I can't do them anymore. They're just frustrated with doing them. And they may just say, oh, I just don't have any interest in doing them. So sometimes that's a key. Not everybody participates in word games. My experience is about maybe 60%, 65% of people do something on a semi-regular basis. They'll do a crossword a couple of times a month, and they just stop doing them. An individual can best be assessed by sequential testing. So even though we might send people for very, very, very 3-hour sophisticated neuropsychology testing, sometimes the best thing we can do is actually see them today, and then see them in 6 months or 12 months and see if they've declined over time. So we're only testing them against themselves. Primary brain areas affected are the broken Wernicke areas and the connections between them. That's not really too important. Let's go on to the next slide, please. So here, this is something that's very easy to measure. It's the visual spatial deficit. And I'm going to give you an example of that. So it's an early finding. It's not found in some of the other dementias. So there is some specificity to this. It's a very objective feature, and I think it's easy to test. So it's very helpful in my practice. The primary area affected is called the parietal occipital connections. It's not the actual visual part of the brain itself, the vision, which is called the visual cortex. It allows sight. It's not affected. It's patients can see something, but they have difficulty interpreting what they see. Next slide. So here's an example without the color. I just put the color in here for the slide, but I would draw a box, and then I would tell the patient, would you please copy this box? So next slide. So here's the example of a patient. His initials were MZ, and I drew the one on the left, and I asked him to copy it, and he drew the one on the right. Probably say it's not too bad. There are certain things that I see there that make me suspicious, but it's really not too bad for an 89-year-old man. Next slide. A year later, 13 months later, if you look at the bottom, I drew the one on the left, and look at what he drew on the right and compare it to the one above, which was 13 months earlier. And by the way, if you look at the errors that are made, these also follow a pattern that I'm used to seeing with Alzheimer's dementia. Next slide, please. So the fourth cardinal feature that I look for when I'm making a diagnosis of Alzheimer's disease is called anosognosia. So this is the lack of insight into one's health or survivorship condition. Patients who have this deficit are unlikely to be concerned about their own cognitive problem, even when confronted with a diagnosis or prognosis. So if I said to this patient, if I said, I think this is Alzheimer's dementia, they don't care. They're not concerned about it. And this is not just depression sort of an issue. And by the way, it's also not a blowback. It's not, you're crazy, there's nothing wrong with me, you know, something like that, because that person does have concern about what I said. So these are people who just are not concerned about it. They don't challenge it, they're just not concerned. Anosognosia can also be found in some other mental illnesses. That could be found in, especially can be found in schizophrenia. It can be found in strokes of the non-dominant hemisphere, and particularly it can be found in what we talked about before, frontotemporal lobe dementia. The primary area affected is, we don't exactly know where it is. There's lots of research, and we'll go into it because we're still not sure. The term anosognosia comes from Greek. It's nosos gnosia, which means not disease knowing. That was about 120 years ago that the term was developed. Next slide. There are other findings besides what I call my four cardinal features. They have impaired executive function, the inability to plan or complete a task. There are emotional behavioral changes, but this may or may not be I should say these are always a later finding, but they may or may not be present initially. Apraxia, the inability to perform physical tasks. So for example, in later diseases, people will have the inability to dress themselves or to feed themselves. And then sleep disturbances, especially loss of circadian rhythm. That means the ability to be awake during the day and asleep at night. This has to do with something called melatonin. But they seem to lose this, and they're very often sleeping a lot during the day and much so less at night. I mean, this is not just taking a nap during the day. They just stay up most of the night, and they're up and down. Next slide, please. The emotional behavioral changes are always found in the later stages, but may or may not present early on. And some of these emotional behavioral changes include depression, anxiety, especially with agitation. This, by the way, may be the most difficult aspect to manage for caregivers. It often requires really special caregiver education and training. And by the way, when I presented early on, Alzheimer's Association, alz.org, they have a lot of material in there to help caregivers. There may be hallucinations. They may occur later in the dementia process. If they occur early, as I told you before, I'm usually thinking of a Lewy body process. There may be delusions, and when there are delusions, paranoia is often the theme to many of these delusions. Next slide. Prognosis, usually talk about people living for 5 to 8 years, but many patients can live way beyond 10 years. I had one patient who lived 20 years with this disease. We do have medications. We have, I'll describe them in a few minutes, cholinesterase inhibitors, NMDA receptor antagonists, and a monoclonal antibody. Next slide. So some of you may be familiar with some of the names. The cholinesterase inhibitors include Aricept, which is donepezil. These are the trade names in parentheses. Rivastigmine, known as Exelon, and galantamine, which is known as Razodine. There is one medicine called an NMDA receptor antagonist called Namenda or memantine. The above medications improve neurotransmitter availability. So in those synapses between two neurons, these medicines improve the amount of transmission of the neurotransmitter, usually acetylcholine, but sometimes something else that goes. And this allows for better neuron to neuron signal transmission. So we're basically helping or covering up in some of the deficits. Next slide, please. So aducanumab, trade name Aduhelm, it was approved just about 3 months ago. A lot of you may have heard of it. This is the first disease-modifying treatment approved for Alzheimer's disease and dementia. So we talked about disease-modifying treatment, something that actually goes to what is causing the problem, as opposed to just helping along. So when you give, well, I don't want to get into, I don't want to get too much into other diseases. So I'll just say this is the first immunotherapy approved for treatment. It's a monoclonal antibody that works by removing amyloid plaques from the brain. So that's what makes it disease modifying. It's going towards the source of what we think is the problem. Unfortunately, clinical improvements during the testing phase have proved minimal to date. There were two major studies. One of them showed an improvement. The other one didn't show much improvement. So why did the FDA approve it? Well, they approved it based upon the data that showed removal of amyloid plaques. And I'm going to show you an example of this in a minute. Now, you might say, well, gee, aren't we looking for better clinical benefit where people are shown to have better memories and things like that? It's still early for that. I will tell you, for example, when the FDA approves a medication for cancer, very often the only thing they have to show is disease modifying benefit. So they'll show that the tumor shrinks, but the FDA is not necessarily going to wait to see after 5 years if people are living longer. They'll continue to demand those studies go on, but they're not going to wait the extra years because they have at least shown that the tumor shrinks. So in this particular case, the same thing has occurred, and their further clinical data is to be measured over the next few years. By clinical data, I mean, are memories improving? Are people able to do things better that they weren't able to do before? Next slide, please. So I'm going to try to explain what's going on here. I want you to first look at the left column, and you'll see, these are called amyloid PET scans. These are PET scans that pick up amyloid or beta amyloid or amyloid plaques. So if you look at the column on the left, they're all pretty much about the same. Now, you'll start from the first, then go down to the second, third, and fourth. Now, these were baseline. On the right, the first one is the person in this, this is just one study. This was, by the way, not an accumulation of many studies. This was just a few patients in an earlier phase 2 trial. So the first one on the top, it says placebo. This is someone who got the placebo, did not get the actual aducanumab. The second, going down, the second, third, and fourth person received aducanumab in different dosing. So you look at the second one, it says 3 milligrams per kilogram, then 6 milligrams, and then 10 milligrams, which is considered the major dose. Now, if you compare each of these to their own baseline to the left, you'll see that in each case, people that received this medication cleared beta amyloid or amyloid plaques from their brain. Now, this is not everybody. This is not cumulative. This is just 4 examples that they used in their earlier trials. Next slide. So are there any negatives to aducanumab? A major side effect is the development of inflammation in the brain manifested on MRI findings as edema, which means swelling, and small hemorrhages, microhemorrhages. The amount of microhemorrhages might lead to the discontinuation of the drug. Now, don't think that inflammation is a bad thing, because the way a monoclonal antibody works, or any antibody works, is by going to the site of disease, causing an inflammatory reaction to fight that disease, and then eventually a clearing of it. We do this with our own antibodies that we develop for any number of viral diseases, COVID or bacterial infections. So remember, we're trying to get an inflammatory response. It's all about measuring it, and we want to make sure we get just the right amount of inflammation to help, and not too much that we actually get hemorrhages within the brain. This medicine, aducanumab, is administered by IV infusion every 4 weeks. And as of right now, we don't really have an end date. We hasn't been around long enough to say when we stop this medication. MRIs, as you might think, are obtained at least sometime in the year before starting it, as well as before doses at weeks number 7 and 12. That's where we look for the edema, the swelling, and for microhemorrhages, and decide whether or not we need to hold the drug. Next slide, please. So when do we use this medication? Well, first of all, we're very, very early, and we haven't been giving it to a lot of people. I'll explain at the end of this slide. It's indicated, the FDA has indicated for patients with mild Alzheimer's dementia, and surprisingly, patients who have mild cognitive impairment with Alzheimer's disease. So So we know that they have the disease, but they don't have the full dementia. So to ascertain that the patient has Alzheimer's dementia or that they have mild cognitive impairment of the Alzheimer's type, the biomarkers need to be obtained before starting the medication. Presently, the acceptable biomarkers are the amyloid PET scan, which I showed you before, and I'll explain in a few minutes, or cerebral spinal fluid analysis, which we obtain by a lumbar puncture or a spinal tap. Now, some bad news right now is presently Medicare has not approved covering the cost of an amyloid PET scan. The average cost is anywhere from $2,000 to $4,000, and it's done privately. Okay, so this is not a Medicare covered test. Also, as of what I've read today, I mean, Medicare has not approved the cost of covering aducanumab. So Medicare is not covering aducanumab. And as of right now, the medication cost is expected to be about $56,000 a year. Now, Medicare will decide if they will cover it, just like they cover a lot of chemotherapies despite the cost. And it isn't just Medicare, it's Medicare plus all of the Medicare Part D plans. It gets very complicated. So it is quite expensive. I will tell you that as far as a lumbar puncture, Medicare does cover the lumbar puncture. And the company that makes aducanumab right now, Biogen, will cover the cost of the actual testing of the fluid. There are two labs that they work with. One is the Mayo Clinic, another is LabCorp. And if the spinal fluid is sent there, they are saying that they will cover the cost of that. Next slide, please. So how do we diagnose Alzheimer's dementia? Well, we do a comprehensive mental status examination using one of the cognitive tools. There are actually about 115 tools listed from the National Institute of Aging. Most of us out in the field here use one of a couple of them. One is called the Mini Mental Status Exam of Folstein, and the other one is the MOCA, or the Montreal Cognitive Assessment. That's the one that most of us are using in our offices. We also do a complete history and physical examination with special attention to the neurological exam and the medication list. Very, very vital in evaluating someone. As far as labs, we get basic labs, usually some chemistries, a blood count. We always check a thyroid level, a vitamin B12 level. You know, we don't think that those deficiencies should cause dementia, but they certainly can cause mild cognitive impairment, and anything else that's appropriate given the history or physical. So if you suspect this is a problem or that is a problem, of course, we'll test for that. We also, most of us also check for syphilis and HIV. We usually do some form of x-rays, usually an MRI or at least a CAT scan of the brain. Some patients may benefit from further testing from a neuropsychologist. And of course, we need to consider the biomarkers, which are the amyloid PET scan or the cerebral spinal fluid, the lumbar puncture tests, especially if it's needed for aducanumab or if there's any other desire. I will also mention that we mentioned ApoE4. That is also something we could test. That's just a regular blood test. Next slide, please. So what is the amyloid PET scan? I told you I would discuss this briefly. So there's a monoclonal antibody against the beta amyloid that's injected, and this binds to the amyloid plaques, the beta amyloid plaques, and it can be seen on the PET scan. You notice that red, I'm going to show it to you again, and that shows the uptake of this antibody. This is considered fairly diagnostic for Alzheimer's disease, especially at age 75 or less. So it's not terribly helpful at ages above that, certainly above 80, I wouldn't do it. The test loses some of its specificity for the disease at later stages because normal people can develop amyloid plaques and they don't lead to dementia. This is just part of the aging process. We can do the lumbar puncture and look at the cerebral spinal fluid to look at various combinations of amyloid, beta amyloid and tau, abnormal tau. And here's good news, there's very, very good progress being made now for the development of a blood test as an acceptable biomarker. And a lot of us think this will be out very, very soon, possibly within the year. And some of us think that that may be why Medicare is kind of shuffling its feet on approving the amyloid PET scan, because they are very expensive, hoping that the blood test will come in and not require the scan. Next slide. And pretty much that was the left-hand side of the slide I showed you before. The red is the uptake. This patient who was injected with a monoclonal antibody that was tagged and comes out as the red. That's the positive amyloid PET. Next slide. We're going to go into prevention. I'm going to try to speed up a little bit, partly because this is stuff that I went through in the first lecture. If you remember in the first lecture, I said up until the prevention, I said, gee, everything here is normal aging, normal aging, normal aging. When we got to prevention, I said a lot of the studies are mixed studies looking at general cognition, just general memory, as well as the development of dementias. So these are kind of some of the same studies. I'm going to go over them quickly, however, and they are mixed. So let's go on. Next slide, please. Recall from early in this lecture, we talked about that over the past few decades, there's been a decline in the incidence of Alzheimer's dementia by about 15% per decade in the United States. This has been attributed to the adoption of healthier lifestyles. We eat better, we smoke less, and we get more exercise. Also recall from lecture number 1, the major interventions to maintain and improve cognition are good exercise, proper diet, cognitive training, socialization, and a low-stress lifestyle. Next slide, please. I'm going to mention something called BDNF, brain-derived neurotrophic factor. It is a protein that is found in the nervous system responsible for both the survival of existing nerve cells, neurons, as well as the growth of new neurons. We mentioned that this can occur, especially in the hippocampus. It's well known that exercise can increase the production of BDNF several fold, so remember that. Also, it's known that exposure to stress can decrease BDNF activity. Next slide. I'm not going to go through everything here because of time, and we did some of it before. I want you to look at that second study, the Canadian study on health and aging. There were 4,000 older adults who started this study with normal cognition. They did not have MCI, and they did not have any dementia. The most physically active people had 50% less Alzheimer's disease, and even those that were physically active but at a lower level of physical activity were found to have 33% less Alzheimer's disease. Next slide. Promise not to go into too many rat experiments, but if you remember Fred Gage's study from the 1990s, this was the first time we found out that you can actually grow new nerve cells. He found that exercised rats spent a lot of time every day on the wheel. They grew new hippocampal cells. Obviously, they were able to, at the end of the study, sacrifice these cells, open up and look at their brains under a microscope. Erickson Kramer, I am going to describe this study he took. Erickson Kramer at the University of Illinois did an interventional study. They took 120 older adults. 60 were given aerobic exercises to do for 1 year. 60 were given stretching and toning exercise for 1 year. They found at the end of the year that the aerobic exercise group showed improvement in memory testing, and on MRIs were found to actually have increased hippocampal volume. So they had bigger hippocampi. Next slide, please. We're going to talk now about the diet. I'll go to 3 studies. They're all important. The Predimed study had over 7,000 people. There were 3 groups. The first 2 had Mediterranean diets to eat. One had extra olive oil. The other had extra nuts. And the third wasn't just a plain old bad Western diet. It was actually a standard low-fat diet. The study was actually stopped early before the 5 years due to overwhelming evidence of less mortality from cardiovascular diseases. Secondary outcomes, however, were measured, and one of them was cognition, how they were thinking. There was improvement in memory, frontal lobe cognitive function, and global cognitive testing. So their memories were better, cognition was better in this study. Next slide. The DASH diet, many of you have heard of this. It's basically a diet for preventing hypertension, but they focus in this diet on limiting sodium especially, portion control in meals, and eating a variety of plant-based foods. Besides cardiovascular benefits, there were neurocognitive benefits found in a sub-study at Duke, and those that ate this diet plus added physical activity did even better on their memory tests and other neurocognitive tests. Next. Mind diet. Now, this is a hybrid of the Mediterranean and DASH diet. This was developed at nearby Rush University. And I bring this one in because it showed 50, so this one is actually showing an Alzheimer's disease improvement. Those people that followed the Mind diet very, very, very carefully had 50% less Alzheimer's after the period of study. And even those who followed the diet but didn't do as well following it showed 35% less Alzheimer's dementia. This diet is noted especially to be rich in berries and green leafy vegetables. Next slide, please. What about brain games, cognitive interventions? I just want to tell you, we're going to be talking about cognitive training and not stimulation. Cognitive training is done for people who do not have dementia. We do also use it for people with mild cognitive impairment. Stimulation is what we use sometimes with patients with dementia. It shows advantages in socialization, caregiver interaction, communication. So we're not going to talk about that now. We're going to talk about actual cognitive training. Next slide. And one of the reasons we talk about it is because it's marketed very, very, very heavily. Narrowly focused activities such as many computer games marketed as enhancing cognitive function and marketed as decreasing dementia risk. So I'm talking about crossword puzzles and Sudoku, but of course those are not computer games. These things help only in the performance of that activity. The benefits do not cross over to other activities, even within the same domain. So if you like doing crossword puzzles, that's great. There's nothing wrong with doing them, but that's going to help you be better at doing crossword puzzles, but it's not going to help you in other types of semantic types of problems. So the Institute of Medicine, because of all of this marketing, the Institute of Medicine in 2015 established criteria in how to evaluate cognitive training products. Next slide, please. So one of the things is you use an active control. So you don't use one group that's doing the game and the other people do nothing. They'll be doing something else on a computer. Transfer of benefits to other tasks, at least within the same domain. So if it's speech and language, they improve in speech and language. If it's visual spatial, they improve in other visual spatial things, not just in the game that they're playing. These benefits transfer to real world tasks. So for example, there's something called the FUOV, and this is a visual sort of a game. And they showed that these people who have completed this not only do better on other visual spatial things, but actually have fewer car accidents. So this is a real world benefit. The fourth criteria is that this lasts for a reasonably long period of time, and that the benefits are replicated by research groups other than the ones that are actually selling the product. Next slide. There are a few commercial products that do use the Institute of Medicine's guidelines as the basis of their product, and you should look for this if you are looking for brain games. However, if you're looking for cognitive training, the most general recommendation we have is to participate in intense intellectual engagement activities, such as taking a course. You know, it doesn't have to be a standard academic course. So if you're very interested in world history, take World History 101 or the French Revolution or something like that. But it could be something else that you enjoy doing. It could be reading, it could be dance, it could be sewing, it could be photography. It doesn't have to be a very academic course. Or you can learn a second language, or if you know two, you can learn a third, or things like that. Don't forget, if a course is taken at a school or community center, there are other benefits that are true, from socialization and some amount of extra physical activity. Next slide. To talk a little bit about socialization. I'm not going to go over this study again, the Karolinska Institute study this was called the Betula Project. And they looked at 1,200 older adults starting in the 1980s. Those who had strong social connections had 60% less dementia. And I presented more in the previous lecture. I'm just going to give you this conclusion. Next slide. There was a University of Illinois interventional study, which I think time is going to prohibit us from getting into, by Elizabeth Stein Morrow. Basically, two groups. One was a group where people were divided into 6 to 8 people, and they went through a certain project together. They had 20 meetings. And then the controls were given the same project, but they had to do them on their own at home. And then after they test these people after a year, not on the project, but on other different domains like memory, executive function, they improved in the experimental group that worked together. They socialized, improved in all 6 areas and exceeded the control group. Next slide. Stress. So the adrenal glands respond to stress by secreting some hormones, adrenaline from the medulla, cortisol from the cortex. These are required by the body, especially adrenaline, to handle stressful situations. You've all heard of fight or flight. And cortisol is very important to be excreted in a medically stressful situation. So if you've had a heart attack or severe infection, your cortisol levels are supposed to rise significantly. Next slide. So stress and high cortisol levels lead to cognitive decline. So if we take rats, and I'm not going to do a lot of this, but if you take rats and you have 3 groups, one is rats that you look at the end of a year, at the end of their lifetime, and you find that their hippocampuses have decreased in size. If you take the adrenals out of those rats at an early age, you find that there's less hippocampal neuronal loss. Similarly, in the third group, if you injected them with extra cortisol, they lose more hippocampal cells. The proposed mechanism for this is related to the BDNF, the brain-derived neurotrophic factor that we talked about earlier. Next slide. How do you limit stress? Well, that's easier said than done. You know, telling a patient, you know, you have to limit stress, that's easier said than done. Counseling, exercise, socialization, meditation, mindfulness, yoga. There's a number of things that you can advise to decrease stress. Next slide. So prevention summary, exercise, specifically aerobic exercise. There's very strong medical evidence. Diet, there are several diets, Mediterranean DASH or MIND diets. There's moderate medical evidence. Cognitive training, especially in intense intellectual engagement, such as taking a course. You can use a commercial product. Look for the Institute of Medicine guidelines and see if they're actually marketing that as one of their benefits. Socializations, there isn't a great amount of medical evidence, but we know it's important, and the same thing for stress management. Next slide. So when should you be concerned? We're almost finished here. Any acute change in mental illness should be considered an emergency and healthcare professional consulted immediately. If the onset of hallucinations or delusions warrant immediate medical concern, and you should consult someone right away. Gradual loss of memory or other cognitive domains over a 6 to 12 month period is more concerning than the gradual change over many, many years. The latter should lead to healthcare professional consultation, but just might be normal aging. Remember, normal aging includes mild episodic memory loss, mild slowing of thinking, and a little more difficulty in multitasking, but these develop over many years. And simple tip of the tongue forgetfulness is common, especially if you later recall the forgotten word. An acceleration of this problem, however, over 6 to 12 months should warrant consultation with your healthcare professional. Next slide. It's always a good idea I think it's always a good idea as you get older to have a baseline mental status exam. It's much easier for us to compare your results to a previous baseline test than it is to look up your score on standard tables or charts. A mental status exam should be conducted by a medical professional experienced in performing and interpreting. It doesn't have to be a doctor, but any medical professional who knows how to do these tests. They are available online to do by yourself or to have a buddy do it. You know, I would ask you not to do that because you might kind of learn some of the questions, and you may try to, you may even unintentionally be practicing some of those things, and it doesn't lead to a proper result when you're examined at a medical facility. Many medical personnel do a mini, I'm going to double the mini on here, the mini exam during just general physicals to decide if it's necessary to do further testing. That might be as simple as, I'm going to ask you to remember three words, gives you 3 words, and 5 minutes later you're asked to what those 3 words were. Results of your mental status exam might warrant referral to a neuropsychologist for more extensive testing, but your healthcare professional should perform a full physical exam first, review your medications, alcohol use, etc., and perform any necessary tests. Remember, we find that sometimes people have problems that are not primarily cognitive. They may have decreased blood flow to the brain and things like that. So I think that a regular examination is warranted as well. Next slide. Oh, I guess that's it. So thank you. I'm going to go through a few of the questions. I'll try to go through them quickly. The big one is, when should you be concerned? I hope you got some of this out of the talk. We're not talking about simple memory lapses. We're talking about things that interfere with your ability to do things. A lot of people want to know about forgetting a word. That's called, by the way, there's a name for that. It was coined by William James, who's the brother of the author Henry James, about 125 years ago. It's called presque-vu. So he described this, it's a normal thing. It does get a little bit worse as you get older, but people in their 20s and 30s get it as well. People with dementia will get it, but it will be much worse. Little hint that I've always used: if you remember what that word was, you do the dope slap, and an hour later something reminds you what that word is, then kind of you remember that you had forgotten it. If you never remember what it is, then I think I have a little more concern. Also, if you're concerned about this, if you remember, you're really concerned about it, you don't have anosognosia. Now, anosognosia is not, the inability to understand your problem. There are actually studies that show that if you're very, very, very worried and concerned and you go to the doctor, most likely you don't have a severe cognitive deficit. But, those are very general ideas. Certainly consult a physician or another healthcare professional if you have questions. Question, does learning to play a musical instrument slow the brain aging? I love this one. I don't know the answer. I would assume that the answer would be yes. That's just a guess on my part. There was a study on dance, which is half music and half movement, done in 2019, which did show that there was less white matter decline. It was over 6 months. Of course, we don't know if it was the music. We don't know if it was the learning the dances. We don't know if it was the physical activity. I think their premise was it was the physical activity. But guess what? You're going to a dance class. You're socializing as well. And probably, if you're dancing, you're probably a little less stressful. So it's a lot of things to go. Question here: which specific exercise is recommended? It has to be aerobic. I did discuss one particular study where they did aerobic. By the way, that study was done on treadmills, and the control did stretching and toning. I want to specifically say that aerobic exercise is not weightlifting. Weightlifting is good. These are anaerobic exercises. They're good. And in a real good program, you're going to do a fair amount of aerobic exercise. You will do stretching and toning to start. Then you'll go to some aerobic exercises, and usually say a few times a week you can do some weight exercises. You always want to make sure you get a good warm up, and we kind of like to say that the best you can do for both cardiovascular as well as cognitive function is 150 minutes a week of moderate activity, moderate physical activity, 150. So that's 5 times a week, 30 minutes, or 3 times a week, 50 minutes. Okay, there was a question about the ApoE4 gene. I will tell you, as far as that's concerned, that can be tested by your physician. I have very few people, very, very few people actually want to do it. There are 3 genes. There's ApoE2, 3, and 4. 4 is present in about 8.4% 4% of the population. There is an increased risk of you getting Alzheimer's disease if you have it. The risk is much higher if you have both alleles, both genes at that location are the ApoE4, but that's only about 1.5% of the population. And one of those ApoEs, the 2, is actually that's found in about 8.5% of the population. That's actually a little bit on the protective side. And by the way, everything we talked about prevention, and we have data on this as well, exists also if you have ApoE4. That's the kind of the bad one to have. So everything that we talked about prevention is also effective in the ApoE4 people. A bunch of questions about alcohol. We don't know the answer fully. You've probably heard that a glass of wine or one a day is healthy for you. You may have heard men can have 2, women 1. After 65 for both sexes, it's usually 1. They talk about that for cardiovascular benefit, and guess what? That's being re-examined now, even the 1 dose. I would think if you have mild cognitive impairment or an ApoE4 gene, that you probably should stay away from alcohol. Alcohol is a neurotoxin. We absolutely know that. Having less alcohol means less neurotoxicity, but there still is some. So the jury is kind of out on that, but if you do have the ApoE4 gene, that was a specific question for me, or you have MCI, mild cognitive impairment, I would tend to stay away from it. Are there medications that get in the way of memory? Yes, we're pretty much out of time. I will certainly say sedatives, such especially benzodiazepines, other sedatives as well, anticholinergics, there's a lot of medicines that are listed as anticholinergic. For lack of time, I'll just tell you to look those up. A lot of products used for bladder incontinence, hypnotics, that includes the classical Z sleeping pills like Zolpidem, Ambien, and of course narcotics. All of those decrease memory. Now, also another question was regarding risk of dementia. We now know that benzodiazepines that include alprazolam, an Ativan, lorazepam, Valium, and a lot of the sleeping medications, temazepam, and those type of benzodiazepines, as well as some of the hypnotics, they do increase the risk of Alzheimer's disease. So that's something we should know. Racial and ethnic differences. There is. African Americans are 2 times as likely to get Alzheimer's as white people, and Hispanics 1.5 times as likely. This may have a lot to do with inequities of care. We especially consider that because at the diagnosis, it's more likely that if you are one of African American or Hispanic, that if you do have Alzheimer's disease or another type of dementia, it's more likely to be diagnosed in a later level, in a moderate or severe level, than it is for white Americans. I would have to imagine disparities in healthcare has a lot to do with that. And I think I am going to stop right there. I think we're just about, in fact, I think we're a minute past. Samantha, anything to add?
Hi, so just one other question. Does Zoom socializing count as normal socializing?
Absolutely. As far as we know, if you Zoom with a group and you're all involved, I don't have the data for that. I have to assume that if you're Zooming with a group, that is some amount of socialization. It's one thing you learn as a doctor. You do what you can when you can. You may have a patient who's 450 pounds and you can't examine their liver. You can't feel their liver. You do the best you can with what you've got. And the same thing, I think if you can socialize by Zoom, it's probably better than not socializing by Zoom. But I don't have any data. I don't have any studies. They're probably out there. I have not seen them though.
All right, well, thank you so much for all of that great information, Dr. Grumet, and thank you everyone for attending today. I hope you found the presentation informative and helpful. Please be on the lookout for the follow-up email that will include a recap and information on additional resources as well as a feedback survey. Thanks again, and we look forward to seeing you at the next Levy Longevity Series presented by AMITA Health.